So today we shall be discussing about some of the regimens which are used in different types of cancers, and to remember it easily, some of the abbreviations are available which are internationally accepted. So let us see the BHEMP. This abbreviation means B for vincristine, A for amitriptyline, which is nothing but methotrexate plus 6-mercaptopurine and prednisolone. And this particular regimen is used in the treatment of acute leukemia. Same as COAP, COAP. C for cyclophosphamide, O for oncovin, A for cytarabine plus prednisolone. Folfiri means 5-fluorouracil plus leucovorin plus irinotecan. This folfiri is used in the treatment of colon cancer. Now Folfox means 5-fluorouracil plus leucovorin plus oxaliplatin. ABBD, adriamycin, that is doxorubicin plus bleomycin plus vinblastine plus dacarbazine, which is used in the treatment of Hodgkin's lymphoma. CHOP means cyclophosphamide, hydroxyrubicin plus oncovin plus prednisolone plus this R stands for rituximab. This is nothing but monoclonal antibody, and this is very used nowadays for the treatment of non-Hodgkin's lymphoma. BEP, B stands for bleomycin, E stands for etoposide, and platinum, P for platinum, and this particular regimen is used in the treatment of testicular carcinoma. So you have to remember these regimens and their short name so that you can easily use in the treatment of different types of patient. Now I shall be discussing about the treatment of some cancers which are not important for pharmacology, but these are important for your medicine examinations and at the same time for your life. And these are the very common cancer which I have included here. Now you see, you will agree with me, acute lymphoblastic leukemia. ALL is very common, and it is the main form of leukemia in children, and it is the most common form of cancer in children. Children with this disease have a relatively good prognosis. Mind it, this type of patient has good prognosis, completely cured, may be cured. A subset of patient with some of the neoplastic lymphocyte expression surface antigenic features or has a poor prognosis. So now a cytoplasmic enzyme expressed by normal thymocyte terminal transferase is also expressed in many cases of acute lymphatic leukemia. T cell ALL also expresses high levels of enzyme adenosine deaminase. This led to the interest in the use of ADA inhibitor pentostatin for the treatment of such T cells cases. Until 1948, the median length of survival in acute leukemia was only 3 months. With the advent of methotrexate, the length of survival was greatly increased. Subsequently, corticosteroids, 6-mercaptopurine, cyclophosphamide, vincristine, daunorubicin, and asparagines have all been found to be active against this disease. A combination of vincristine and prednisolone plus other drugs is currently used to induce remission. Over 90% of the children enter complete remission with this therapy with only minimal toxicity. However, circulating leukemia cells often migrate to sanctuary sites located in the brain and testes. The value of prophylactic intrathecal methotrexate therapy for prevention of central nervous system leukemia, a major mechanism of relapse. So when you are treating this cancer with the drugs used peripherally, you will find some of the remnants of the cancer will be remain in the brain, and that may cause relapse of the disease. So intrathecal administration of methotrexate reduces this relapse rate. So intrathecal therapy should therefore be considered a standard component of the induction of regimen for children with acute leukemia. Now adult leukemia. Adult leukemia, acute it is acute myelogenous leukemia, AML. It was previously known as acute myeloid leukemia, but nowadays it is known as acute myelogenous leukemia. It's the most common leukemia in adults. The single most active agent for AML is cytarabine. However, it is best used in combination with anthracycline antibiotic, which leads to the complete remission in about 70% of the patient. While there are several anthracyclines that can be effectively combined with cytarabine, idarubicin is preferred. Patients often require intensive supportive care during the period of induction of chemotherapy. Such care includes platelet transfusion to prevent bleeding, the granulocyte colony stimulating factor filgrastim to shorten periods of neutropenia, and antibiotics to combat infections. Younger patients, example age less than 55, who are in complete remission and have an HLA mesh donor are candidates for allogenic bone marrow transplantation. The transplant procedure is preceded by high dose chemotherapy and total body irradiation followed by immunosuppression. This approach may cure up to 35 to 40% of eligible patients, and patients over age 60 respond less well to chemotherapy, primarily because their tolerance for aggressive therapy and resistance are lower. Remission of AML is achieved. Consolidation chemotherapy is required to maintain a durable remission and to induce cure. Now, chronic myelogenous leukemia, CML. Now, chronic myelogenous leukemia arises from the chromosomally abnormal hematopoietic stem cell in which a balanced translocation between the long arms of chromosome 9 and 22 is observed in 90 to 95% cases. This translocation results in constitutive expression of the BCR and ABL fusion oncoprotein with a molecular weight of 210 King-Armstrong. The clinical symptoms and causes are related to white blood cell count, and its rate increases. Most patients with white cell counts over 50,000 per microliter should be treated. The goals of the treatment are to reduce the granulocyte to normal levels, to raise the hemoglobin concentration to normal, and to relieve disease-related symptoms. The tyrosine kinase inhibitor imatinib is considered as standard first-line therapy in previously untreated patients with CML. Nearly all patients treated with imatinib exhibit a complete hematological response, and up to 40-50% patients show a complete cytogenic response. As described previously, this drug is generally well tolerated and associated with minimum adverse event. Initially, dasatinib and nilotinib are approved for patients who are intolerant or resistant to imatinib. Each shows clinical activity, but both are now indicated as first-line treatment of chronic phase of CML. In addition to this tyrosine kinase inhibitor, the other treatment include interferon alpha, busulfan, and other oral alkylating agent, and hydroxyurea. Now, chronic lymphocytic leukemia. Patients with early stage of chronic lymphocytic leukemia have a relatively good prognosis, and therapy has not changed the course of the disease. However, in the setting of high-risk disease or in the presence of disease-related symptoms, treatment is indicated. Chlorambucil and cyclophosphamide are two most widely used alkylating agents for this disease. Chlorambucil is frequently combined with prednisone, although there is no clear evidence that the combination yields better response rates or survival compared with chlorambucil alone. In most cases, cyclophosphamide is combined with vincristine and prednisone, or it can also be given with the same along with doxorubicin, CHOP. Bendamustine is the newest alkylating agent approved for use in this disease either as monotherapy or in combination with prednisone. The purine nucleoside analog fludarabine is also effective in treating CLL. This agent can be given alone in combination with cyclophosphamide and mitoxantrone and dexamethasone, or combined with anti-CD20 antibody rituximab. Monoclonal antibody targeted therapies are being widely used in CLL, especially in relapsed or refractory disease. Rituximab is an anti-CD20 antibody that has documented clinical activity in this setting. This chimeric antibody appears to enhance the anti-tumor effects of cytotoxic chemotherapy and is also effective in settings in which resistance to chemotherapy is developed. Alemtuzumab is humorized monoclonal antibody direct against CD52 antigen approved for use in CLL, that is refractory to alkylating agent or fludarabine therapy. Response rate up to 35% are observed with disease stabilization in another 30%. Now Hodgkin's and non-Hodgkin's lymphoma. So first of all, you just consider Hodgkin's lymphoma. Hodgkin's lymphoma. The treatment of Hodgkin's lymphoma has undergone dramatic evolution over the last 30 years. This lymphoma is now widely recognized as a B-cell neoplasm in which the malignant Reed-Sternberg cells have rearranged B8 genes. In addition to Epstein-Barr virus genome has been identified up to 80% of the tumor specimens. Complete staging evolution is required before a definitive treatment plan can be made. For patients with stage 1 and stage 2A disease, there has been a significant change in the treatment approach. Initially, these patients were treated with extended field radiation therapy. However, given the well-documented late effects of radiation therapy, which include hypothyroidism and increased risk of secondary cancers and coronary artery disease, and combined mortality with a brief course of combination and involved field radiation therapy is now the recommended approach. The main advance for patients with advanced stage 3 and stage 4 Hodgkin's lymphoma came with the development of MOP. MOP means M for meclorithabine, O for vincristine, P for procarbazine and P for prednisone. The regimen results initially with high complete response rate on the order of 80 to 90% with cures up to 60% of the patient. More recently, the anthracycline containing regimen term ABBD, doxorubicin, bleomycin, clinbastin, dacarbazine has been shown to be more effective and less toxic than MOP, especially with regard to the incidence of infertility and secondary malignancies. In general, 4 cycles of ABBD are given to patients. An alternative regimen termed Stanford-B utilizes a 12-week course of combination chemotherapy, doxorubicin, vincristine, meclorithabine, vincristine, bleomycin, etoposide, followed by involved radiation therapy. With all of these regimens, over 80% of the previously untreated patients with advanced Hodgkin's lymphoma, stage 3 and 4, are expected to go into complete remission with disappearance of all disease-related symptoms and objective evidence of disease. In general, approximately 50 to 60% of Hodgkin's lymphoma are cured for the disease. Non-Hodgkin's lymphoma, and that is more rare. Non-Hodgkin's lymphoma is heterogeneous disease, and the clinical characteristics of non-Hodgkin's lymphoma subsets are related to the underlying histopathologic features and the extent of disease involvement. In general, the nodular lymphomas have a far better prognosis with a median survival rate up to 7 years compared with diffuse lymphoma, which have a median survival rate about 1 to 2 years. So combination chemotherapy is the treatment standard for patients with diffuse non-Hodgkin's lymphoma. The anthracycline containing CHOP has been considered the best treatment in terms of initial therapy. Randomized phase 3 clinical studies have now shown that the combination CHOP with anti-CD20 monoclonal anti-rituximab results in improved rates, disease-free survival and overall survival compared with CHOP chemotherapy. The nodular follicular lymphomas are now low-grade, relatively slow-growing tumors that tend to present in advanced stage and are usually confined to lymph nodes. Bone marrow is considered incurable and treatment is generally palliative. To date, there is no evidence that immediate treatment combination offers clinical benefit over the close observation, watchful waiting with the initiation of chemotherapy at the onset of the disease symptoms. Next common tumor is multiple myeloma. This plasma cell malignancy is one of the models of neoplastic disease in humans, as it arises from the single tumor stem cells. Moreover, the tumor cell produces a marker protein, myeloma immunoglobulin, that allows the total body burden of tumor cells to be quantified. Multiple myeloma principally involves the bone marrow and bone, causing the bone pain, lytic lesions, bone fractures, and anemia, as well as increased susceptibility to infection. Most patients with multiple myeloma are symptomatic at the time of initial diagnosis and require treatment with cytotoxic chemotherapy. Treatment with combination of alkylating agent melphalan and prednisone has been standard regimen for nearly 30 years. About 40% of the patients respond to MP combination, and the median remission is on the order 2 to 5 years. Recently, combination including lenalidomide plus dexamethasone or the proteasome inhibitor bortezomib plus melphalan and prednisone have been shown to be more effective as first-line therapy. In patients who are considered candidates for high-dose therapy with stem cell transplantation, melphalan and other alkylating agents are to be avoided, as they can affect the success of stem cell harvesting. Thalidomide is a well-established agent for treating refractory relapse disease, and about 30% of the patients will achieve a response to this therapy. More recently, thalidomide has been used in combination with dexamethasone, and response rates on the order of 65% have been observed. Studies are now all underway to directly compare the combination of vincristine, doxorubicin, and dexamethasone with the combination of thalidomide and dexamethasone. In some patients, especially those with poor performance status, single agent pulsed dexamethasone administered on a weekly basis can be effective in palliating symptoms. Bortezomib was first approved for using relapsing or refractory multiple myeloma and is now widely used in the first-line treatment of multiple myeloma. This agent is thought to exert its main cytotoxic effect through inhibition of 20S proteasome, which results in downregulation of the nuclear factor kappa B signaling pathway. Of note, inhibition of nuclear factor has been shown to restore chemosensitivity. Based on this site of action, further efforts are focused on developing bortezomib in various combination regimes. Breast cancer. First, initially stage 1 and stage 2 disease. The management of primary breast cancer undergone a remarkable evolution as a result of major efforts at early diagnosis, though encouragement of self-examination as well as through the use of cancer detection centers and the implementation of combined modality approaches incorporating systemic chemotherapy as an adjuvant to surgery and radiation therapy. Women with stage 1 disease, small primary tumors and negative axillary lymph nodes dissection are currently treated with surgery alone, and they have an 80% chance of cure. Women with non-positive, node-positive disease have a high risk of both local and systemic recurrence. Thus, lymph node status directly indicates the risk of occult distant micrometastasis. In this situation, post-operative use of systemic adjuvant chemotherapy with 6 cycles of cyclophosphamide, methotrexate, fluorouracil, or of fluorouracil, doxorubicin, and cyclophosphamide has been shown to significantly reduce the relapse rate and prolong survival. Alternative regimens with equivalent benefit include 4 cycles of doxorubicin and cyclophosphamide and 6 cycles of fluorouracil, epirubicin, and cyclophosphamide. Each of these chemotherapy regimens has benefited women with stage 2 breast cancer with 1 or 3 involved lymph nodes. Women with 4 or more involved nodes have had limited benefit, thus far from adjuvant chemotherapy. Long-term analysis has clearly shown improved survival rates in node-positive premenopausal women who have been treated aggressively with multi-agent combination chemotherapy. The results from 3 randomized clinical trials clearly show that addition of trastuzumab and monoclonal direct against HER2 new receptor to anthracycline and taxane containing adjuvant chemotherapy benefits women with HER2 overexpressing breast cancer with respect to disease-free and overall survival. Breast cancer was the first neoplasm shown to be responsive to hormonal manipulations. Tamoxifen is beneficial in postmenopausal women when used alone or in combination with cytotoxic chemotherapy. The present recommendation is to administer tamoxifen for 5 years of continuous therapy after surgical resection. Longer duration chemotherapy do not appear to add additional clinical benefit. Postmenopausal women who complete 5 years of tamoxifen therapy should be placed on aromatase inhibitors such as anastrozole or for at least 2.5 years, although the optimal duration is unknown. In women who have completed 2 to 3 years of tamoxifen therapy and treatment with aromatase inhibitor for a total of 5 years of hormone is now recommended. Results from several randomized trials for breast cancer has established that adjuvant chemotherapy for premenopausal women and adjuvant tamoxifen for post-women are benefit to women with stage 1 node-negative breast cancer. While this group of patients has the lowest overall risk of recurrence after surgery alone, this can be further reduced with adjuvant therapy. Now, stage 2 and stage 4 disease, stage 3 and stage 4 disease, breast cancer. The approach to women with advanced breast cancer remains a major challenge as current treatment options are only palliative. Combination chemotherapy, endocrine therapy or combination both has overall response rate 40 to 50%, but only 10 to 20% complete response rate. Breast cancer expressing estrogen receptor or progesterone receptor retain the intrinsic hormonal sensitivity of normal breast, including the growth stimulatory response to ovarian, adrenal and pituitary hormones. Patients who show improvement with hormonal ablative procedures also respond to the addition of tamoxifen. The aromatase inhibitor anastrozole or letrozole are now approved as first-line therapy on women with advanced breast cancer whose tumors are hormone receptor positive. In addition, these agents and exemestane are approved as second-line therapy following treatment with tamoxifen. Patients with significant involvement of the lung, liver or brain or those with rapidly progressive disease rarely benefit from hormonal maneuvers. An initial systemic chemotherapy is indicated in such cases. For 20 to 30% of the breast cancer patients whose tumors express HER2 nuclear receptor, the humanized monoclonal antigen trastuzumab is available for therapeutic use alone or a combination with cytotoxic chemotherapy. About 50 to 60% patients metastasis respond to initial chemotherapy. A broad range of anti-cancer agents have activity in this disease, including anthracycline, doxorubicin, mitoxantrone, epirubicin, the taxane, docetaxel and paclitaxel, and albumin-bound paclitaxel, along with microtubule inhibitor, ixabepilone, nebibin, and gemcitabine, cyclophosphamide, methotrexate, and cisplatin. The anthracycline and taxanes are two of the most active classes of cytotoxic drug. Combination chemotherapy has been found to induce higher or more durable remission in up to 50 to 80% of the patient, and anthracycline containing regimens are now considered the standard of care in first-line therapy. With most combination regimens, partial remissions have a median duration of about 10 months and complete remissions have a duration of about 15 months. Unfortunately, only 10 to 20% of patients achieve complete remission in any of these, and as noted, complete remission is not long lasting. Now, prostate cancer. Prostate cancer was the second cancer shown to be responsive to the hormonal manipulations. The treatment of choice for patients with advanced prostate cancer is elimination of testosterone production by the testes through either surgical or chemical castrations. Bilateral orchidectomy or estrogen therapy in the form of diethyl steroid was previously used as first-line therapy. Presently, the use of luteinizing hormone-releasing hormone agonists, including leuprolide and goserelin agonist, alone in combination with anti-androgen protamide and bicalutamide and nilotamide is the preferred approach. There appears to be no survival advantage of total androgen blockade using combination of LH-RH agonist and anti-androgen compared with single agent therapy. Hormonal treatment reduces symptoms, especially bone pain, in 70 to 80% patients and may cause significant reduction in the prostate-specific antigen level, which is now widely accepted as a surrogate marker for the response to treatment in post-cancer. Although initial hormonal manipulation is able to control the symptoms up to 2 years, patients usually develop progressive disease. Second-line hormones include aminoglutathione plus hydrocortisone, the antifungal ketoconazole plus hydrocortisone alone. Unfortunately, near all patients with advanced prostate cancer eventually become refractory to hormone therapy. A regimen of mitoxantrone and prednisone is approved in patients with hormone refractory prostate cancer because it provides effective palliation in those who experience significant bone pain. Estromycin is an antimicrobial agent that produces almost 20% response rate in single agent. However, when used in combination with either etoposide or taxane such docetaxel or paclitaxel, response rate has more than doubled in 40 to 40%. The combination of docetaxel and prednisolone was recently shown to confer survival advantage when compared with mitoxantrone prednisolone regimen, and this combination has now become the standard care for hormone refractory prostate cancer. Lung cancer. Lung cancer is divided into two main histopathological subtypes, non-small cell and small cell. Non-small cell lung cancer makes up about 75 to 80% all cases of lung cancer, and this group includes adenocarcinoma, squamous cell carcinoma, large cell cancer, while small cell lung cancer makes up around only 20 to 25%. When non-small cell lung cancer is diagnosed in advanced stage with metastasis, the prognosis is extremely poor with a median survival rate of about 8 months. It is clear that prevention and early detection remain the most important means of control. When diagnosed at an early stage, surgical resection results in patient cure. Moreover, recent studies have shown that adjuvant platinum-based chemotherapy provides survival benefit in patients with pathology stage 1, B, 2 and 3A disease. However, in most cases, distant may have occurred at time of diagnosis. In certain instances, radiation therapy can be offered for palliation of pain, airway obstruction or bleeding to treat patients whose performance status will not be allow for more aggressive treatments. Patients with advanced disease, systemic chemotherapy is generally recommended. Combination regimens include platinum agent, appear superior to non-platinum doublets, and either cisplatin or carboplatin appropriate platinum agent for such regimens. For the second drug, paclitaxel and vinorelbine appear to have activity dependent on history, while antifolate P matrix should be used for non-squamous cell carcinoma and gemcitabine for squamous cell carcinoma. For patients with good performance status and those with non-squamous history, the combination of anti-VEGF antibody bevacizumab with carboplatin and paclitaxel is standard treatment option. In patients deemed not to be appropriate candidates for bevacizumab therapy and those with squamous cell history, a platinum-based chemotherapy regimen in combination with anti-EGFR antibody cetuximab is a reasonable treatment strategy. Maintenance chemotherapy with pre-matrix is now used in patients with non-squamous cell whose disease has not progressed after 4 cycles platinum-based first-line chemotherapy. Finally, first-line therapy with an EGFR tyrosine kinase inhibitor such as erlotinib or gefitinib significantly improves outcome in non-small cell carcinoma of the lungs cancer patients with sensitizing EGFR mutations. Small cell lung cancer is the most aggressive form of the lung cancer and it is exclusively sensitive, at least initially, to platinum-based combination regimen including cisplatin, etoposide or cisplatin or irinotecan. When diagnosed at an early stage, the disease is potentially curable using a combined modality approach of chemotherapy and radiation therapy. Unfortunately, drug resistance eventually in nearly all patients with extensive disease. The topoisomerase 1 inhibitor topotecan is used second line monotherapy in patients who have failed platinum based. Now this is very common cancer in case of female, ovarian cancer. In the majority of the patients, ovarian cancer remain occult and become only symptomatic after it has already metastatized to peritoneal cavity. At this stage, it is usually present with malignant ascites. It is important to accurately stage this cancer with laparoscopy, ultrasound and CT scanning. Patient with stage 1 disease appear to benefit from whole abdomen radiotherapy and may receive additional benefit from combination chemotherapy with cisplatin and cyclophosphamide. Combination chemotherapy is the standard approach to stage 3 and stage 4 disease. Randomized clinical studies have shown that combination of paclitaxel and cisplatin provides survival benefit compared with the previous standard combination of cisplatin plus cyclophosphamide. More recently, carboplatin plus paclitaxel has become a treatment of choice. In patients who present with recurrent disease, the topoisomerase inhibitor topotecan, the alkylating agent L-tetamine and liposomal doxy are used as single agent monotherapy. So these are the some of the treatment of some common cancer. I have given this only two, not for pharmacological examination but for your future. Thank you, my dear students.